Okay, good morning. Hello, and happy Friday, everyone. Welcome to today's webinar. My name is Hiva Kolodrubetz. For those of you who don't know me, I'm a family nurse practitioner. I'm also the director of advanced practice here at Archer, and I'm really excited about today's webinar because this is a topic that's been coming up internally within our Archer team as we are continuing to adapt our products to make sure that they are the most current according to what the test plans are out there for our board certification. But this is something that I think a lot of students haven't really thought about, or maybe you've heard some rumors about. So I really wanted to prepare this webinar for you guys so that you can really, knowledge is power. Get ready for the changes that are to come. So if you're joining me today, you're probably either a family nurse practitioner student or getting ready to start your NP clinical or didactic training. So you really need to know what those changes are that are coming up. We will just be talking about ANCC today. So as you know, as you probably know, there are two different board certifying bodies. There's the ANP and the ANCC for the family nurse practitioner track. Today, we're just talking about ANCC, the American Nursing Credentialing Center board certification, their FNP exam changes that are coming up this October. ANP has not transitioned to this content yet. We'll keep an eye on it for you guys, so make sure you continue to follow Archer as things are evolving, and make sure that your test plan reflects your Q bank, your questions, your study material reflect the test plans that are current. So that's what we're going to talk about today. And I see a lot of you joining us, which I love to see. A lot of new faces, a lot of recurring faces, which is great. This is going to be interactive, so you don't have to wait to the end to ask questions. I'm going to be exhibiting some practice questions from our question bank that we're building out for you guys. So you can practice what this content looks like. So get that chat box open. Go ahead and introduce yourselves in the chat box. I'd love to see who's joining us. Where are you in your training? And are you sitting for the ANCC? Are you considering sitting for the ANCC? Love to see who's in the audience today. So go ahead and throw that in the chat for me. So you may or may not have heard about this test plan change. I have had students asking me some questions, and I thought, you know what, I'm seeing some recurring themes. So let's talk about some of the rumors that are floating out there. Hi, Kelly. Good morning from San Francisco, California. Excellent. So this is early for you. Um, so let's talk about some of the things that I'm hearing recurring in terms of misinformation that's out there that my students are talking about. So my students are saying, Hiva, is the whole exam format changing? The answer, short answer is no, right? Exam format staying at 175 questions, 150 of them are scored. You have 3.5 hours to do it. Plenty of time. If you don't feel that, come talk to me after this webinar, but plenty of time. And it's still that 150 questions with 25 unscored. We don't know how many are unscored, so treating every single one as if it's the real deal, and getting adequate time to answer those questions. Next question my students will ask is, does this mean the exam's harder, right? Should I rush to take the board certification before the test plan changes, right? My answer is no. Do not rush, right? Going in prepared for your board exam is going to set you up for success, and rushing to sit for a board certification that you're just not ready for, regardless of what that content is a bad idea. So do not rush, right? And it's not necessarily that the exam's getting harder. It's just reflecting what we're seeing in clinical practice. Remember, board certification is not there to trick you. It is a safety checkoff, right? We are making sure that we have equipped you with the knowledge that you need to be able to safely practice at an entry level when you enter clinical practice. So this is really more peace of mind. So if we're repeatedly not passing the board certification, I want you to come talk to me, because we really need to talk about, well, what's going on? Where are those knowledge gaps that we need to fill to set you up for success, right? This is a checkoff. This is not a hurdle meant to prevent you from entering clinical practice. We need more clinicians. So please do not rush it. And it's not necessarily getting harder, it's just getting reweighted differently because our role in clinical practice is changing, right? So ANCC is doing a really great job making sure that our board certification reflects our current role in practice. We're seeing students entering clinical practice with more autonomy, less support. So that bar, that threshold for entry level is changing. Right. So we need to adapt with that in our education to make sure we're setting up the future generation for success. That is the bottom line, right? So don't make a fear-based decision. Really go into it with knowledge and information so that you can be prepared. Preparation is key. So today's webinar, we're not only going to talk about those changes, but I'm going to really talk about those shifts in the content, three particular new content areas that we're going to talk about. AI is now in the board certification that's going to be taking effect in October. We're going to talk about diagnostic interpretation, right? This one's really, really important, especially for making sure you're ready for clinical practice. And then social determinants of health and sexual health. Those are the three big buckets in terms of content. And we'll talk about what that means in terms of the blueprint and how things are shifting. And then we'll talk about those test dates and then give you a practical step-by-step of how you can move forward after today's webinar. All right, so those are the big takeaways from today. I'm looking at the chat. You guys are awesome. Look at you. Okay, so we said hi to Kelly Marie this morning. Alu, welcome back from Minnesota, FNP, ANCC. Okay, Alu, when are you taking your ANCC? I want to know. Anna from Florida. Good morning, Anna. Great to see you. Carolina from Florida as well. Ooh, lots from Florida this morning. I love it. April from Utah. Robin, last didactic semester, Houston, Texas. I'm in Texas as well. Welcome, Robin. Planning ANP, but want to be informed. Beautiful. Love to see that. Yelena, Boston, Massachusetts. That's where I'm from. Very cool. Considering ANCC. Yelena, what program are you in? I am a UMass Memorial out in Worcester alumni. So let me know where you're training. I'd love to see that. Gifty from Connecticut, welcome. Doris from Florida, done with school, ready to test. Very cool. Courtney, good morning, Courtney from Washington, D.C. ANCC exam before September ends. Okay, so you're on the old test format. We're going to talk about the differences. Diane, or am I saying that right? Diane from Virginia, FNP, ANCC. Okay, Diane, when are you getting ready to sit for the ANCC? I want to know the date. Kathy, ANCC as well. Same question to you, Kathy. When are you sitting for ANCC? Gifty, considering ANCC. Again, tell me the date, you guys. I want to know, you guys, before or after. It might impact you depending on when you're planning to test. Yelena, you have your hand up. Can you put it in the chat for me? Not sure if you have a question or if you're just really excited to be here. And Naria, good morning. Great to see you as well. Okay. Estella from Arizona, October before the change date. Okay, so I see a lot of hesitation. Need to take it before October 16th is what Kathy is saying, considering end of September, considering ANCC. Okay, I'm seeing a lot of you saying ideally before the test plan change. So let's talk about the changes and maybe this webinar will change your mind a little bit. So don't be afraid of the test plan change. If you walk away with nothing, except for one thing out of this webinar, do not be afraid, right? This is for our profession. So this is good. So why ANCC updated it, as I mentioned, our entry level expectation or necessity to really be practicing a safe entry level when we enter clinical practice has really shifted, right? We're seeing that as educators, we're seeing that as experienced clinicians, we're seeing that gap in our newer clinicians coming into clinic, and we're really trying to figure out how can we best support you, right? To really get through that steep transition into clinical practice and set you up for success. So the ANCC really took an expert panel and surveyed 2,500 practicing FNPs, right? To really get a accurate landscape of what are you expected to know? What do you face day to day in your clinical practice? And from that, they really adopted those key content areas that are impacting our clinical practice. So this is not just willy-nilly, this is really trying to reflect our current role as primary care clinicians. What's not changing is our primary role, right? We are nurse practitioners, we are advanced practice registered nurses. Our main goal, this is FNP, family nurse practitioner, is primary care in that outpatient setting, right? That is what we're being trained for, seeing across the lifespan. We really need to be comfortable with those common conditions, both acute and chronic, that we see in that primary care clinic. We need to be able to assess our patients. We need to be able to diagnose them, right? Come up with a list of differentials, know what data points we need to rule in or rule out different diagnoses, be able to come up with an appropriate plan of care, be able to appropriately implement that plan of care. That's really important. We're going to talk about that today. And then be able to evaluate, are we meeting our goals? Or do we need to adjust this plan of care? That is what an advanced practice registered nurse is, right? So none of that is changing. We need to make sure with all that, we bring our nursing core. We're going to educate our patients. We're going to follow up with our patients. We're going to use our clinical judgment and assess, how is this patient doing holistically, right? None of that is changing. This is all just more technical terminology to really set us up for that holistic care that we provide as advanced practice registered nurses. So none of that is changing. It's really our central core is still staying true. The key dates, a lot of you said early in October. Key dates to really keep in mind, there is going to be a blackout date, meaning that the old test plan, you can sit for it all the way up through October 18th. And then October 19th to 29th, no test dates will be given out. If you are somehow signed up for a test date, you need to contact ANCC and change and reschedule your test date because this is a blackout date. They're not giving any tests because this is when they're changing everything over in the system. And then October 30th is the first day that that new test content applies. So if you are testing on October 30th, you're getting the new test plan. If you're testing on October 18th, you're getting the old test plan. Anywhere in between, you're not getting either. You can't test, right? Maybe you're sitting for AANP, but not ANCC. So remember the dates. But do not rush it, right? That's the key takeaway from today. We're not acting out of fear. So this slide really just says what I've been saying. Do not rush it. If you feel like, you know what, I've been studying for a few months, I graduated, I want to really take my boards within that 30 to 45 day window after graduation to really keep things fresh in my brain, I feel ready, then go ahead and take it, right? If you're like, I'm about to graduate, I'm finishing up, I haven't even started looking at study material, but I'm really worried about this new test plan, but I don't feel ready. Do not rush it, right? I feel like I'm saying that 20 million times, but I think you guys get the picture. Let's not beat a dead horse. All right, so now we're going to talk about these domains, right? This is a lot of terminology that we as nurse educators are familiar with because as we write and teach and train our new nurse practitioners, we really have to think about these buckets. But I want to break it down for you guys and how it will be relevant to you as you're studying, right? So the 5 domains that we're talking about are what we said we do as nurse practitioners, right? We assess our patients, diagnose, create a plan of care, implement that plan of care, and evaluate our patients. So those buckets or domains are staying the same, whether it was the old test plan or the new test plan. What is changing is how much weight we put in those different buckets. The biggest takeaway is this implementation bucket, and this is probably where students get the most intimidated when they're thinking about ANCC. They think implementation, that's just going to be about rules and regulations and scope of practice. It's just a lot of terminology that I don't care about. I'm going to break down what that implementation looks like, but note that it really is a large chunk of the exam. So that weight we've heavily stepped on that. And it's about a third of the test now in that new test plan. We've also seen some other shifts just to make that possible, right? A little bit of downshift in those other domains. However, that doesn't mean that they're not important, right? So let's talk about what that looks like. So that big mover, really implementation is going to be about a third of our test. What does that mean? So again, it's not just rules and regulations. Yes, we have to know our scope of practice. We have to make sure that we are advocating for ourselves in clinic when we have administrators or our physician colleagues or maybe our PA colleagues who haven't gone through advanced practice registered nurse training. When we have them putting things on us that are not within our scope, we have to respectfully say, hey, this is my scope of practice, right? So we have to be comfortable with our scope of practice so we can advocate for ourselves. Because other people going down different tracks of their training to help feed this healthcare ecosystem may not understand what our training is. So it is our job to help our colleagues really understand where we contribute in this healthcare ecosystem. So yes, that's important, but that's not all implementation is, right? Implementation simply means, are you able to effectively and safely implement the plan of care that you've come up with? This is appropriate plan of care. That not only includes documentation and scope of practice, but it also includes, does my patient understand this plan of care? Is this feasible for my patient? Right? So patient-specific education, therapeutic communication. How am I communicating this plan of care to my patient? Does my patient know what success looks like? What is our goal? Is it a shared goal? Have we had that discussion? That's all part of implementation, right? What are the resources that I need to pull in from this healthcare ecosystem to help implement this plan of care to make sure we're setting our patients up for success so we can meet our goals? That's implementation, right? These are things that we do as nurses, right? And we're now just talking about it as a domain, so in terminology, but it's real nursing practice, nursing care, right? It also includes that pharmacologic and non-pharmacologic intervention. So we're not just focused on pharmacology, we're also pulling in that non-pharmacology. That's what's beautiful about advanced practice RN. We're pulling in our nursing care. And I love that. And that's why I became an advanced practice registered nurse. That's why I became a nurse, right? Really looking at the patient holistically. So pulling in those non-pharmacologic interventions as well. And now we have responsible technical use, including AI. How do you guys feel about that? How many of you have seen artificial intelligence in some shape or form in your clinical rotations, in your current role as a nurse? How many of you have seen it? I want to see that in the chat. Yeah, we kind of have it. Yeah. So in this survey that ANCC sent out, it almost felt like, it's speaking as a clinician and an educator, it almost felt like last year artificial intelligence blew up. And it's not that it blew up just in regular society, it blew up in the clinical world. All of a sudden, it was everywhere. Colleagues are saying, hey, have you tried this? How are you using that? It's saved me time, X, Y, and Z. And it's become uh, very obvious that we need to not only support our new grads on responsible use of this technology, but also develop some guardrails for everyone in the community. How are we responsibly implementing and using this technology to protect our license, to protect our patients, protect privacy, all those things that we think about when we use technology in healthcare. So that's where we're really seeing AI in clinical practice. So I'm seeing a lot of you say, yes, oh my gosh, look at all these different names. And I love how they how they name them real people names like Heidi AI and Roger AI. I know. But yeah, I see a lot of you saying, yeah, I'm seeing it. Hi, Ellen. Good morning. Welcome. Yeah, and I see it a lot too. And I want us to feel comfortable with how we're going to use it, right? So let's talk about implementation a little bit more. Oops, going too fast. So implementation, we really talked about really that nursing care, right? So what does that look like? Mini case study. We have a 54-year-old patient, newly diagnosed with stage 1 hypertension, no end organ symptoms, kidney functions normal. This patient's hesitant to start medication, right? How many of you have had this patient, right? You guys use the hand raising. How many of you have had this patient? Yeah, I know I have this patient like every day. And so implementation is really asking the why, right? Why is this patient hesitant to start medication? Do we need to implement more patient education, have that conversation about what's happening pathophysiologically in hypertension that's putting this patient at risk, putting their organs at risk for further complication? Is this a knowledge gap? Is this patient thinking, I'm not sick? I don't have any signs or symptoms. Stage one, my kidneys are fine. I'm feeling fine. Why do I need to take medication? So patient education belongs in that implementation bucket, right? Is what the plan of care, what we've come up with, was that shared decision making? Or are we just putting it on our patients saying, this is what you need to do, X, Y, and Z? I remember as a new clinician, I used to have the perfect plans of care. I used to be like, oh, this is textbook. This is exactly what you need to do. And then they'd come back for follow up and I'm like, you did none of it. What happened? Right? It's because it was not shared decision making. I was telling my patients what they needed to do instead of asking, okay, this is what the research shows. This is what I'm trying to protect you from, right? This is how I'm trying to keep you healthy. What seems feasible? What can we work on between now and our next follow-up, right? So really talking about the plan of care with your patients and implementing it so it's realistic, that's a huge part of our care that we provide to our patients. Scheduling that follow-up, documenting appropriately so that follow-up, you know what you guys talked about, what you didn't talk about, where you're going to pick up on that visit with that patient. All of that is part of that implementation bucket. So don't be scared of that implementation bucket. You're probably already doing it, right? You're already doing it. All right. So I forgot I put a slide in, so let's jump back into AI. Okay. So AI, no longer just a workplace issue, I want to say, it is now exam content, right? How many of you, we've talked about this, think that AI is now fair game? Should we be tested on it? I want to know. So I see that some of you are seeing, Terry says, I see it in the clinic. Evan saying, I'm seeing it. How many of you think AI is fair game? Alu says, I'm seeing it. Should it be on the board certification? I want to know, yes or no. So really talking about that responsible use, let's jump into what a scenario testing our responsible use could potentially look like. Ooh, I like that, Robin. Robin says no. I don't think we should have AI. Tell me more, Robin. Do you guys agree with her? What do you think? All right, let's read this case scenario. So how could it potentially show up as a test question, right? An organization approved ambient artificial intelligence documentation tool generates a visit note for a 48-year-old patient evaluated for worsening asthma symptoms. The assessment, treatment plan, prescribed medications, it accurately reflects the encounter. During the visit, the nurse practitioner notices that the history states the patient denied nocturnal symptoms, but cannot verify that this information was obtained during the visit. How many of you have been wrapping up your notes at the end of the day? You've done that rough draft of your note so that you can go on to the next patient without forgetting who that patient was because they all start to blend together. So you want to make sure you document as much as possible, but you don't close it to the very end till you proofread it. I know I do that, right? To really keep with pace of clinic, but also make sure I have good documentation. And then at the end of the day, I'm like, oh my gosh, did we discuss that? Because in your brain, you're thinking, well, I would normally discuss that, but did we actually discuss that, right? So in this scenario, you're thinking, did we discuss nocturnal symptoms or did I forget to talk about that? The discrepancy, however, does not change today's clinical management. Okay, so it doesn't change anything in the visit, but now we're just talking about documentation. So did we discuss those nocturnal symptoms? What do you think? A, B, C, or D? Think about responsible use of technology. Are we going to verify the history before authenticating the note? Are we going to remove it from the note, remove the unsupported statement, and authenticate the note? Ask staff to review the encounter recording, so the transcript, go through the recording, or are you going to de-authenticate the note because nothing changed in that plan of care, management didn't change, so it's okay. We'll just authenticate and move on. What do you guys think? A, B, C, or D? What's going to be responsible use of technology? Catherine, Gifty, love it, out the gate, locking in their answers. What do you guys think? This is tricky, right? Because it's easy, it's tempting to do a few of these options without giving away the answer. All right, going once, going twice. Final answer is A. So really what we need to do, best practice, verify the history before authenticating the note. So that means, okay, we're going to call that patient tomorrow and say, did we talk about your nocturnal symptoms? We need to talk about that, right? Because that is part of our severity scale about their asthma symptoms, right? And maybe it might change management, it might not, probably not. However, we need to make sure that we get a full history, right? Think about AI as a tool to really help guide us to make sure we're not forgetting things. If we just remove it, that's not okay, right? Not responsible technology use. Though I'm not going to lie, I would in the past just think, well, if it didn't happen, I'm not going to document, so I'll just remove it and then authenticate my note because I'm maybe in real life before AI happened, I would forget to document that because I never asked it, so it wouldn't be in my note anyway. So it's tempting. It's tempting to just remove it and authenticate that note and move on, right? But then it's like, oh, but that is part of a thorough history. Let me call that patient tomorrow, right? Don't close that note out yet. That's responsible AI use. Um, Asking staff to look at the recording, not responsible. It is our responsibility. Authenticating the note either way because it doesn't change. Again, not accurate documentation, not responsible tech use. So really thinking about what is the safest action, right? Similar scenario here, but ambient note notes that medication allergy the patient denies. Um, what's the appropriate thing here? We're not going to sign the note because the AI pulled that allergy for the patient from the EHR, so it's accurate. We're not going to avoid AI altogether in practice, right? We can use these tools to help us, right? Help us make sure we're gathering all the relevant information. Sometimes it might be over interpreting things. We really need to make sure we're verifying the note and before we close it out. But we don't want to avoid these tools altogether, right? It should really help reduce some of that administrative burden. But really the best thing to do is to use it as a administrative tool and verify and correct any documentation before signing it. So that's the biggest takeaway with AI. So I'm curious to know how many of you now think, yes, we should be tested on it, or no, we should not be tested on it. So Robin, what did you say? I was curious because it's not a standard across the board for all states, regions, not everything hospital system or healthcare office can integrate or use it. Okay, I like that case. What do you guys think? So Robin's saying, no, it shouldn't be on the boards because it's not consistently used in our healthcare system. Some clinics have it, some clinics don't. Some clinicians use it on their own, some don't. But could that be the case about really anything when it comes to healthcare, right? So we get tested uh, on diagnostic tools that not every clinic has, like when we're doing a KOH, right? So is that a valid argument? I don't know. What if you then enter clinical practice, your first clinic doesn't have it, but your next one does? Is that part of the breadth of knowledge that we really need to have to protect us and be able to really serve our patients throughout our career, right? I think about that as technology changes. I can't see the harm in it, right? Okay, Robin, thank you. I appreciate you too. Yeah, I've email me. I'm curious to hear more. Yeah, it should be to safeguard the patient information, help us with documentation, says Catherine. I think I agree with you, Kathy. I also agree that it's really more there to help us, right? This is to make sure we have the knowledge that we need. All right, so let's talk about those new content areas specifically. We talked about AI as one, diagnostic interpretation is another one, and then that social determinants of health and sexual health is the third one. Those are the really big three main chunks that I want you to take away from today's webinar. That diagnostic interpretation, it's not that we were not expected to diagnose our patients or not know what the appropriate diagnostic tools were, but they're asking us to not only be able to select those appropriate diagnostic tools, but be able to really interpret them to help us with our clinical judgment, to really see the whole picture and really create a appropriate plan of care. So it's a shift in that skill. And I think it's an appropriate shift, right? We really need to be thinking about what we're ordering, why we're ordering it, and how is that going to really impact our plan of care, right? So we're seeing a shift in that diagnostic bucket, for lack of a better word. So mini case study, 38-year-old reports fatigue, constipation, dry skin, weight gain. You may have some labs. Now it's going to say, they're going to ask, okay, how are you going to interpret those labs, right? How is that going to affect our plan of care, right? So already things that we were doing, definitely things that we're doing in clinic, but now the test is just catching up to that scope, right? So making it more explicit, not just not just ordering the diagnostics, but interpreting those results. Really important. Let's practice what that might look like. 67-year-old patient presents for a routine visit, reports no palpitations, heat intolerance, tremor, or unexplained weight loss. Lab test shows TSH 0.18. They give you that normal range. Free T4 1.2, normal range is right there. Total T3 128, normal's right there. Patient has no recent acute illness, is not taking thyroid hormone or medications known to suppress that thyroid stimulating hormone. What is the most likely diagnosis? What do you guys think? A, B, C, or D? So they're asking us to interpret, which is something we were already doing, right? So you can argue that this is just a change in terminology for the test plan because we were already expected to diagnose, right? We were already expected to interpret these lab values. So is this really that different? Or are we just being more explicit about it with the way we write it out in our test plans? What do you guys think? A, B, C, or D? Okay, definitely seeing some mixed answers, which if you've joined me for webinars in the past, I love it when you guys are in disagreement because it really lends itself to a nice conversation, a good learning moment. I love the question marks after the answers, going once, going twice. And the answer is D. This is subclinical hyperthyroid. Remember, first thing we're going to look at is this hypo, an underactive thyroid gland, or hyper, overactive, right? We're thinking about primary and secondary hypo and hyper. So it's showing us that thyroid test, that thyroid stimulating hormone is 0.18. So we know it's suppressed, right? Hyper. And then we have to really look at those thyroid hormones themselves. So free T4 is normal and that total T3 is normal. Our thyroid hormone levels are normal. Patient, looking at the overall picture, this is really what they're trying to get at with diagnostic interpretation. How is the patient doing? How are we going to interpret these labs with the overall clinical picture? This patient, no recent illness, is not taking any medication that could be suppressing the thyroid. They report no signs and symptoms of hyperthyroidism. So really, this is subclinical hyperthyroidism, right? Meaning that TSH is suppressed, but those thyroid hormones are normal. Patient's not feeling sick. This is not a euthyroid sick syndrome, meaning that could be transient due to a recent illness. This is not central hypothyroidism, right? First of all, it's not hypo. We're not seeing that TSH elevated, but normally we would see that TSH would be normal with those thyroid levels different, and with the overt and central being secondary due to the pituitary gland. So is the diagnostic interpretation really that different from what we were already expected to know before? What do you guys think based on that example? What do you think? Are you feeling less scared about the new test plan? You're like, oh, this is not that different, right? Not that different. So Kathy's saying, what's the difference between A and D? Very good question, you guys. What's the difference between A and D? That overt hyperthyroidism and that subclinical. So overt, what do you think those thyroid hormones would be? Would they be elevated or normal? And do you think that patient would have signs and symptoms of hyperthyroidism? Yeah. So in overt, it means we're seeing signs and symptoms of hyperthyroidism. Those thyroid hormones are elevated with that suppressed TSH, that thyroid stimulating hormone. Whereas subclinical, yeah, that TSH is suppressed, but those thyroid hormones are still normal and that patient's not symptomatic. Right? Is that helpful, Kathy? Overt is obvious. Ooh, I like that, Evan. I've not heard that before. Overt is obvious. Not always, but I like that mnemonic or the way of thinking about it. Yeah. I think the central is probably the hardest one for people to also really wrap their head around. And again, if we're seeing a patient where we're thinking, okay, their thyroid hormone levels are normal, but I'm seeing the TSH is abnormal, we also want to be thinking about, is this really due to primary thyroid issues or secondary? Okay. So let's go to that third bucket because I know we're a little over time, but I want to make sure you guys have this before you have to hop off. But that third bucket, really talking about social determinants of health, sexual health, that is really being explicitly highlighted in that assessment domain that we saw. Right. So before it used to be treated more as a nice add-on. Now we're explicitly really talking about it as an expectation. We need to look at the full picture with our patients. Why are they not taking their medication? I remember I had a patient, type 1 diabetic, blood sugars through the roof. He just could not afford his insulin and he worked full time, had insurance. He just had bad insurance and not enough money to fill his prescriptions, right? We need to really be thinking about holistically the why behind why our patients are not meeting their goals, right? And that's what this bucket is really trying to highlight for our younger, newer nurse practitioners and clinicians getting out there. So here's this a scenario. Patient presents for a routine follow-up with stable vitals, no acute complaints. Complete risk assessment includes housing stability, food access, safety, sexual history, not only if time allows. So really thinking about what that looks like. Let's practice it in a test question. 2-month-old infant presents for a routine wall child visit. Since birth, the infant's weight has decreased from that 55th percentile to the 20th percentile, so your red flag should be up, while the length and the head circumference continue to follow expected growth curves. What's the growth curve that is preserved until the very extreme scenario? So when we see those growth curves dropping, we typically see one dropping last. Which one is that? Put it in the chat for me. What is usually preserved? Is it the length? Is it the head? Is it the weight? What do we usually see? That head circumference usually the preserved. Yeah, absolutely. I said it funny. I'm sorry, guys. But yeah, the head circumference is usually that last growth curve that we see drop, right? Our body knows how to preserve the head. Usually we see that weight drop first, then length, and then head. Development is appropriate for age. Physical exam is otherwise unremarkable. Caregiver reports the infant feeds every 3 to 4 hours, has adequate wet diapers, appears satisfied after feedings. So all the things, check, 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 right? Okay, feeding every 3 to 4 hours, adequate wet diapers, looks well fed. During the nutritional history, the caregiver states, we're doing pretty well. I can usually make 1 can of formula last almost 6 weeks. Which additional assessment is the highest priority, right? So based on this caregiver's comment, what do you think? A, B, C, or D? Are we going to evaluate the infant's feeding volume? Maybe there's a feeding issue that's leading to failure to thrive. Maybe that we're going to assess the caregiver's formula preparation practices. C, order stool studies and serum lab tests. Maybe it's food sensitivity, allergy. D, assess the family's access to infant formula. What do we think, you guys? A, B, C, or D? Kelly Marie is locking in her answer. What do you guys think? Erica's locking it in. Evan's locking it in. Kathy. Gifty. Oh, I thought this one would be tricky, but you guys are nailing it. Wow. I'm impressed, you guys. Going once, going twice. Anybody else want to weigh in? Correct answer is B, right? We're going to assess that caregiver's formula preparation. Why? Should 1 can of formula be lasting 6 weeks? No, right? That caregiver is probably diluting that formula. Baby's not getting adequate nutrition, right? Maybe they're feeding every 3 to 4 hours, getting wet diapers, but that is a really dilute bottle and that baby's not getting the calories that they need, right? So that is the highest priority, right? And then I would probably also assess the family's access to infant formula, right? Why are we doing that? Is it due to lack of patient education? Or is it a financial strain? Do we have access to enough formula, right? So first, highest priority, I want to see how are we preparing that bottle, right? Then I want to know, do we have access to enough formula for that baby and that family, right? Um, Evaluate the infant's feeding volume. Mom saying infant's feeling full, not hungry. not really thinking that's the issue yet and not thinking about allergies, but those are in the back of our mind when we're thinking about failure to thrive, right? Yeah, between B and D. I know I was hoping some people would say D so we could talk about it, but you guys all nailed it. I'm impressed. All right, so some smaller changes to be aware of so that evaluation is really consolidating. Again, biggest takeaway, evaluate our patients and make sure that our plan of care is working. If it's not, we're going to tweak it, right? We're really being asked to apply the knowledge that we know and not just memorize and regurgitate. That's a recall level question. So there are different levels of complexity in terms of these questions when we're developing them. There's recall, there's application, there's analysis being the hardest, in my opinion, when I'm writing questions, especially. But recall is when they're just asking you just straightforward questions about X, Y, and Z, and you just have to say, this is what that means, right? Like, what is hypertension and the definition of that. Applications, when you know what hypertension is and you're applying that knowledge, you know how to treat it with the different pharmacologic treatments and in applying it to that particular patient case, right? That is applying the knowledge. So they're really asking us to shift in our way of thinking when we are training our new nurse practitioners and expecting our new nurse practitioners to really put that together in the education world in a safe environment before entering clinical practice, because out the gate, we're going to have to be able to do that. Few other small changes, drop that anti-neoplastic category from our drug agent list, again, to reflect that primary care setting, right? They're going to probably see oncology for that. Yes, we're going to have to co-manage those patients, but that's not really knowledge that we need to go in depth on for our primary care clinical practice. It's something that we're going to learn as we're co-managing those patients. And then that diagnosis bucket is really broadening, right? So not just memorizing, regurgitating, but understanding that underlying disease process and why it matters to address it. Because we're going to have to explain that to our patients. Why are we treating hypertension when you feel great, right? Why are we treating your blood sugars when we're talking about hypertension, right? What's happening in that underlying disease process, right? What is metabolic syndrome? What does that mean? Right? So really thinking about that. And that's how the test plan is really trying to adapt and shift. So biggest takeaways, 4-step restudy plan. 1, get the right documentation, know the outline, see the resources. I recently published a blog on Archer's blog about ANCC. So if you want specifics to really get down in the nitty gritty, read the blog. There are links to the test content outline, that reference list in that blog post for you. Think about when you're studying, when you're practicing, not just for the boards, but as you're practicing in clinic and your didactic, you really want to shift your mindset around implementing that plan of care, right? Not just coming up with the correct diagnosis, but interpreting that diagnostic tool into what that means in clinic, what that means for your patient holistically, and implementing something realistic that will help us meet our goals, right? Really, really important. So shift the way you're thinking about these case studies and these practice questions and how you're studying in general. Don't panic. Do you guys all feel a little bit better about this new test plan? You're like, oh, if I had to take it after the switch over, I'd feel fine. Are we feeling less panicked about it? Yeah, it's not as bad as I thought, says Kelly. I agree with you, Kelly, right? This is really just a shift to really accurately portray what we're already being trained to do in our nursing education, right? It's just really shifting to make sure it's staying current with what we're expected to know entering clinical practice. So I think it's really to our benefit personally and as in our profession. And then last, make sure whatever prep resources you use, it does reflect this content, these shifts, right? Um, Here at Archer, we absolutely are not only keeping our finger on the pulse, but making sure our prep material is reflecting current test plans. So we do have AI that we're implementing. All these different questions that we went over today are in our test plan. And we're building out even more, but making sure your prep resources do reflect what you're accurately going to see or potentially see on test day is really, really important, right? So check your test date, check your resources, watch for updates, follow us, right? If you are here at today's webinar, you probably know about Archer, which is great. Tell your friends to follow us. Um, Make sure you're on our email list. You can sign up for demos on the question banks that are free, both for family nurse practitioner and psych mental health right now. So if you sign up, you'll get our emails, you'll get our announcements, you'll know about webinars coming up. Um, Make sure you're staying up to date. Make sure your test plan and the resource that you're using is also staying up to date. That's really, really important. All right, you guys, any questions? I know you guys have been awesome. I'm going to flip through the chat to see if there were any questions that I missed. But any questions that you guys have, you guys can feel free to put it in the chat here. You guys can feel free to email me. For those of you who do email me now, you can attest that I love to hear from you. I love to hear how it's going. What are your pain points? What do you need more of? What are you enjoying? So don't hesitate to email me or connect with me on LinkedIn. I really love to see how things are going for my students. I appreciate that you guys joined today's webinar. If you have a few minutes, you can also leave a review so I can see some of that feedback as well. But thank you so much for joining today, and thank you for sticking it out. I know we went 15 minutes over, but I thought it was important to give you guys all the content. So I appreciate your flexibility, and I hope to see you on our next webinar. Have a wonderful day. So Terry asks, are there any changes for ANP so far? No. That's a great question. We have not seen it yet. They are on different review cycles, but that's absolutely why it's really important to make sure you get on our email messaging board, or what do they call it? Not subscription page, but you have a student account. You can form a student account for free on Archer, but that's the way you get the emails and the updates. So as I keep an eye on things, I will definitely let my students know on our email list. Email list. That's what I was trying to say. So Terry, make sure you get on our email list, and as those changes come up, I do anticipate that ANP is also going to shift a little bit, but they're on different review cycles, so no shift yet, but keeping an eye on that for sure. Yeah. Does ANP have select all that apply? Good question, Alu. No, ANP just has single best answer, right? And we're seeing that shift with ANCC too. So far, they're still saying that they have that alternative format, but a lot of the test questions are single best answer. But they do technically have that select all that apply. They also have the hotspots and drag and drop. So it's just the ANCC that has the alternative format. You're so welcome, Terry. Thank you for joining today. Great questions. You're so welcome, Gifty. All right, looks like that's all the questions. Have a wonderful day, you guys. Bye.